Hello and welcome to our session on reducing waits and delayed access to care. My name's Darren Wright, and within Q I lead on strategy and business development, but also I've taken on quite a lot of the work that we're doing around reducing waits. I think Tanya mentioned in our introductory session that we in Q have committed to start working on the challenges that face you as improvement practitioners in your day-to-day lives. And one of the key challenges we're all trying to sort of manage our way through at the moment is the challenge of waiting and delayed access to care. With 7.75 million episodes of waiting for care in England alone, we can see this is more than a health problem, it's a societal problem that we're going to have to galvanise resource and effort to try and challenge. But we also recognise that that's England. That's just in England, but we also support the 5 nations that we work with, and there are similar sort of challenges around that as well. What I would like to do is just to give you a bit of a background in what we've been doing in relation to waits. And I've got some slides here, which hopefully you can see. I can see that we're getting a few blank screens on the chat there, which is hopefully something we can sort out. As we've been working over the last year on trying to sort of promote the role that improvement can play in managing waits, we've had the chance to focus different bits of our work on this, to the extent that we're now supporting 25 projects which have been created by you as members. 20 of those sit within our Q Exchange programme. And 5 of those are sitting within our Q Labs programme. In terms of our learning and development offer, we've taken visits to the Flow Coaching Academy and the East London Foundation Trust. They've been spectacularly popular with members and given real examples of the role that improvement is been playing around managing waits and reducing delayed access to care. But your engagement with our offers has also taught us quite a lot of things around the issue of waits and how they manifest themselves in your different organisations. So some of the things that we've learned are waits are a symptom, not a cause. And we always work within improvement to try and address the root cause of problems and try and address those. And I think it's really important that we see that the wait is just the public manifestation of the challenges that we have at the moment. We've recognised that our work is both about emergency waits and elective waits. And some of the sort of solutions that you as a community are coming up with can apply in both arenas equally. It's really important to recognise that waits are about people and process. This isn't just the pure application of improvement methods are going to solve these problems. It's really understanding the people that manifest waits. And that's sort of part of understanding that there isn't just a purely industrial process that will move people to flow through pathways and systems. Got some slides there. There is also a really important equity element to who is waiting and how they are waiting. That's come really strongly through all of the different projects that people have talked to us about. And I'll just talk about some learning that we've had from our Q Exchange programme, which sort of backs that up. And we've also learned that improvement has a crucial role in trying to address this. We recognise that there is not unlimited resources in terms of money or people that can ride to the rescue around this. So a lot of the sort of progress we are going to make is going to be led by improvement, is going to be led by the improvement community, and that is you. So what have we learned from the 100 ideas that we got in from you in the community when we asked for ideas as part of our Q Exchange programme? And I think they were both varied and really consistent. So people were very focused on how we improve the efficiency in pathways such as A&E, and how we apply our knowledge about service design and our knowledge about flow and apply that to emergency care. How do we reduce DNAs and change the use of existing services was very current in people's mind. And recognising that we need to increase capacity, people and resources in order to be able to reach more people. There was a really strong focus on prevention and the early interventions, and I think we were pleasantly surprised that when we talked to the community, there was so much enthusiasm and effort to focus on that lower downstream activity to try and sort of address waits before they reach that critical stage. And there's also the realism and recognising that people are waiting and people need to be able to wait well to prevent the deconditioning that we see as people wait for so long, and support them to understand what the process they're taking part in, and how they can support themselves in some way to try and maintain condition. All of these things are not really a surprise, but I think it really sort of cheered us up to see there was such enthusiasm and clarity of ideas that came from the community when we put a call out for sort of ideas that we could support. And these manifest themselves in all of the different projects that we now have running as part of Q Exchange and as part of the Q Lab. This session, what I'd really like to do is try and address sort of a story around this. So recognizing that when we talk about weights, we really need to start with the people. All of those waiting lists are made up of people with their own stories, their own needs, and their own challenges. And if we understand those, then we'll be in a better place to try and address how we sort of sort those needs out within our systems. But we do also need to understand process. And that we need to find some good examples, and we see what works within the community. So I've got 3 excellent guests that have come to talk to us about this. In terms of starting with the people, we've got Chris McGann from Healthwatch that's going to talk about the great work that Healthwatch have been doing to identify the challenges around weights. We've also got Steve Black here, who's a data scientist and analyst. You might recognise him from his contributions to the Health Service Journal, but also quite a lot of work that he's been doing related to the challenges of urgent care and mortality. And we've also got Goody Singh, a paediatric doctor, who's going to talk to us, bring some of her vast experience of world health and international health, but also the experience of a particular Q Exchange project that we've been supporting. One I'm very interested in, because as we recognise from data that became available last week around the 1 million episodes of community waiting there is, recognising that a fair old burden of that is actually being experienced by young people and children. And the Q Exchange project, which I believe Goody will mention, does relate to how we can support young people to navigate services. So 3 really interesting and different perspectives on weights and waiting and how we can address them. What I'd like to do is get each to give us a bit of insight from their own experience in turn, and then we will open up, well, if you think of questions, put them into the chat now, and we'll collate those together and we'll put them to the panel after their introductions, and we'll see if between us we can tease out some answers to the challenges of how improvement can play a role in supporting the reduction of waits and delayed access to care. I would first like to introduce Chris, please.
Hi, folks. Just want to check, can people see the screen that I'm sharing? Yeah. So, hi, my name is Chris McCann. I am the Director of Communications, Insight and Campaigns at Healthwatch England. We are the statutory patients champion for England. So we are the national body, and there are 152 local Healthwatch, one that exists in every top tier local authority in the country. So in terms of the issue around waiting, we're always very keen to get across what the media tends to focus on is that top line figure, the 7.75 million that Darren mentioned there, which is, you know, astronomically high. But what we're always keen to focus on is the fact that behind every one of those figures, every one of those pathways, there's an individual, and that the weight and the quality of the weight has a real impact on those people and on their quality of lives. So what I'm going to do is just take a quick run through sort of the journey of waiting, focusing on elective care, looking at the stage of referral, diagnosis and testing, and then the process of waiting for care. So we know that, you know, from the moment a patient gets referred by their GP for a scan or a test or treatment, individuals are quite likely to face delays due to the pressures the NHS currently faces. And as I said, we're going to go through and have a look just at the various stages of that. So looking at referrals, we did some work on referrals earlier this year, and we know that delays to referrals really causes concerns amongst patients, you know, who have shared their stories with us. It's the first stage in the journey towards treatment. And referral delays means that people often end up waiting a long time before their concerns are addressed. A delay is not just stressful, but it can also mean ongoing pain, sometimes make a person's physical condition worse than they originally referred, and it can have impacts on people's mental health. So our work on GP referrals suggested that one of the issues is that people often have to make several appointments before being referred. So we have a few suggestions for improving people's experience of GP referrals. So better access to GP appointments, particularly through digital telephony. We all, I'm sure, are aware of that 8 a.m. rush where people are trying to get an appointment or trying to get to talk to their GP. And for many members of the public, you know, if they've got, if they're working or if they've got the school drop off to do, they've got caring responsibilities, it's really, really hard for them to do that. So we need to address how that 8 a.m. sort of bottleneck for accessing GPs is dealt with. We also need then to look at more care navigators to ensure a smoother patient journey. And I know that that's something that was referenced in the government's GP access primary care plan earlier in the year. We need greater appointment flexibility. And this is a point that I'm going to come back to throughout the journey, is really clear and regular communication between staff and patients. One of the most stressful things that happens to patients while they're waiting for care is long periods of silence, and it leads to patients constantly feeling that they've been forgotten about and really increases their stress levels. So moving on to getting tested, again, the issues are quite similar. We know that delays for scans and diagnostic tests mean people are left waiting to know whether they have a condition or what are the next steps for them. And people often feel pressured to find out for themselves what is happening, rather than actually being contacted by the services they're dealing with to be proactively informed of where they are on their journey. And searching for those answers can lead to real frustration for people as they find that different services and different departments manage parts of their referral journey. And what people have told us about the urgency of their condition often doesn't seem to be acted on by them. So again, clear and timely communication is important to help patients understand that what tests are being done and why. And then once tests and scans have been completed, people need to know when they can expect results and what to do if they feel that there has been a delay. One of the things that we've heard people refer to is they feel sometimes when they're on a referral, they go into like what they consider like a referral black hole. They just simply don't know what to expect, when to expect it. And that just leads to, as I said, extra stress, extra pressure on people. In terms of getting treatment, we also know that, you know, people can wait a long time for treatment. Waiting times can be described as long very often in the cases that we hear about. And we hear about waiting times that range from weeks to several months. So one of the things that really also has an impact on patients is appointments being cancelled at short notice, which creates further uncertainty about the expected treatment date. People tell us that they accept that there are pressures on the system and that they might have to accept waits for elective care. But they do assume that once they've been given a date, that's the date they'll be treated on, and that they end up having to put their life on hold as they're waiting for procedures related to things like mobility, and subsequent challenges. Cancellations can make them feel forgotten. And the reasons for when people are having changes to the treatment plan are only sometimes made clear to them, which is a real frustration for people. And in terms of people who have had their care disrupted, we found that of people who have had their care postponed, 39% had that happen to them on 2 or more occasions. And 18% of people had their care cancelled or postponed as at the last minute, which the NHS defines as on the day of or on arrival to the appointment. Which again, when you think about the patient experience, if you're waiting for a procedure, you build yourself up. It's quite it can be quite a stressful process, only to find out on the day that the treatment you were expecting isn't going to take place, and you're going to have to go through another wait and then build yourself up for that consultation or appointment again. So again, steps that would help improve people's experience of waiting for care include being really clear about why appointments and elective care have had to be rescheduled, and providing a contact when care has been postponed to discuss the implications and what support is available until treatment is received, so that we can be sure that people are getting the pain relief they need, the mental health support they need, and things like physio if it's required. A key element around that really needs to be addressed when we look at waiting lists is inequalities. When we see these things like long delays for treatment, last minute cancellations, a lack of personalized information, these are huge concerns for people, particularly those from lower income households. Disabled people, those with lower wealth, women, and people from minority ethnic backgrounds are the groups most likely to have experienced long waits for treatment and a delay or a cancellation. Women and disabled people are most likely to have been negatively impacted by their long wait for care, with things like relationships, their ability to socialize, their ability to provide care for a loved one, and mental health and well-being suffering as a result of these waits and delays. We also see that people with lower levels of education are more likely than people with higher education to be happy with the information the NHS has provided for them. And for those people whose identities intersect across several groups, the impacts are compounded and long waits can be much worse. So if you happen to be a woman from a minority ethnic background who's from a particularly deprived area, you'll find that that individual's experience of waiting is likely to be substantially more negative than somebody, for instance, a white British person from an area of low deprivation. So overall, as I said, we've called for really our things as communication is a key one. So NHS processes for contacting patients has to be improved, and a lot of this was accepted in the elective recovery plan. So things like implementing the good patient communications guide. This was a guide that was developed in 2021, but doesn't seem to have been widely implemented. So there is guidance out there about communicating with patients and ensuring that patients don't feel forgotten about by putting in regular updates in place across different communication channels. So understanding whether your patient wants to be contacted by text, email, phone call, a printed letter. So to improve the support people need while they wait, such as providing people with better access to pain management, better access to physiotherapy, better mental health support is really important. Providing support with transport and accommodation where patients choose to travel for quicker care at a specialist hub outside their local area is also very important, particularly for people from lower income backgrounds who might struggle with accommodation and transport costs. And giving people more control over their appointments, giving people better options to feedback about the issues they're dealing with while waiting for elective care procedures. And that includes making it easy for patients to update the NHS when there are changes in their condition, and allowing people to book or view or cancel their appointments through things like the NHS app. So I'll stop sharing there. That's just a very quick sort of run through the sort of overarching themes that we have seen in the, particularly post-pandemic, as we've looked at patients' access to elective care and their experience of waiting. But we've got quite a few sort of specific reports that I'd be happy to share with the group if they want to get more detail underneath the sort of very generalized sort of little run through that I just gave there.
Thank you, Chris. That's excellent. I just want to take the opportunity to use my chair's prerogative to ask a question, but the sort of strong impression that you're giving there seems to be that patients themselves are remarkably tolerant of waiting, but it really is how they wait and the level of information that they get that helps them to wait in more comfort is probably one of the key challenges. Do you think we are taking that seriously?
I think, you know, we see that the NHS is doing a lot, particularly to deal with the longest waiters, and we've seen, you know, those figures for you know 2 years, people waiting 18 months have come down, but that question of communication is pivotal. People know that the system is under pressure, and they know that they might have to wait some time to receive the care that they need. But what they really find unacceptable is when they just kind of feel slightly lost. You know, they know they're waiting. They don't know where they are on the list. They don't know why, for instance, a treatment has been pushed back. And if you can give people that reassurance, give them that point of conduct, it means that there's more to waiting than just the length of the wait. There's the quality of the wait. And if you can improve the quality of somebody's wait, you can really make a real impact on their quality of life as they're waiting for their service.
And that waiting well is something that we do need to resource, and we do need to address with our own improvement activity. And I've seen that reflected in quite a lot of the projects that we're supporting through our Q Exchange program. Thank you, Chris. I know we've got more questions for you, but I'll try and come back to those once we've met all of our speakers. I would like to introduce Steve Black now. Thank you, Steve.
Ooh, right. Okay, you can see my slides. That's a good thing. Let me just make sure I'm ready to go. What I want to do in less than 10 minutes is to try and offer an explanation as to why some of the things you've just heard about, some of the things Chris has said, are actually happening. So my general idea, and we've heard a lot of stuff this morning about, or earlier on, about what sort of tools we can use for improvement, how much we need to do improvement. But one of the things I think is the biggest problem getting started is understanding where the problem is. And I want to try and argue from 3 different pieces of evidence that the real problem with waiting lists is that both the management of the Department of Health, the management of NHS England, and a large number of the management teams in hospitals don't actually understand what the problem is, because they haven't paid any attention to what's behind the curtain in the process by which waiting lists are managed. They're looking at their RTT reports and saying, are we doing well or are we doing badly? And they're sometimes inventing grand theories as to what needs to happen. But none of them are looking at the dirty details of how we decide things on waiting lists, like how to prioritize patients, when we should talk to patients, how to update our knowledge about the patients, how to decide when their appointment will happen. And I think that the fundamental problem is there's been very little attention on that. And that's one of the reasons why we have a problem. So let me go through some of the pieces of evidence. Let's see if I can get control of my slides. So okay, what's on my screen is not appearing on this screen yet. I'm not quite certain whether that's whether there's a sort of technical problem with how the slide shares are working.
Steve, we've actually got your with not presentation mode, so I don't know if you want to stop your share and re-add it as presentation mode.
Let me try this again. Oh, there we go. Is that better? All right, right, that's better, yes. Sorry about that. Right, in preparing for this, I reminded myself of some stuff I'd known about. I did a quick search in the HSJ for some headlines that have happened which say something is very badly wrong with the way we manage waiting lists. And this goes back probably a whole decade or more, but the ones I could fit on a screen start in 2016. It was a horrific story about Great Ormond Street suddenly found it had twice as many patients as it thought it had. How does that happen? What sort of error in managing a waiting list means you suddenly discover a whole bunch of patients, children in this case, who you didn't know were there? Story in 2017, Royal Cornwall had to do a complete review of its waiting lists because it kept getting hit for seriously inadequate performance. And the place they looked was what's wrong with our waiting lists. Imperial College 2018 had to do a double review of their waiting lists because they found they'd lost a whole cohort of patients. How does that happen? Same thing was true at St. George's, where they got severely reprimanded because the problems of managing their waiting lists caused serious harm to a handful of patients. Same with follow-up appointments. Several national bodies review follow-up appointments and say, well, we've got a serious safety problem. How does that happen? Then a report 2021, many staff don't understand what the rules actually are for counting waiting lists, and the patient systems, the electronic systems in hospitals are simply not set up to handle decisions about waiting lists coherently and in a relatively sensible way. Another of these classic stories, we've lost a whole bunch of patients. Dartford had to review 31,000 patients because the IT system somehow lost them. How does that happen? And another one, final one here, a very recent story. We got a bunch of problems with patients getting lost, getting misidentified. Hospitals totally dropped them. So how was that happening? What was going on? Now, one of the reasons why I have some idea about the answers to this is because I've occasionally done audits of hospitals' management systems, usually when they've got a panic about getting punished for submitting inaccurate data to NHS England and their RTT reports. But when you look behind the curtain and you look behind the scenes, you often find that there really isn't a coherent process for managing the waiting list. So in one hospital, we found that the entire cancer pathway was managed by a single individual, entirely manually, on a spreadsheet where he had to copy stuff from several different systems into a spreadsheet. And if he was ill for a couple of weeks, nothing happened and the reports were wrong and it was a mess. The process, very often not documented. In that case, nobody else could take over his job because they didn't know what he did. A lot of hospital processes are manual, multiple data sources, cobbled together, no proper process. So it's little wonder that really big errors creep in when they lose a lot of patients. And part of the cause of this is that both the system as a whole, NHS England and many hospital management teams, what they care about is submitting the RTT reports every month. They get punished if they don't or if they're inaccurate. But they haven't looked beyond that to say, are we doing the right thing for the patients on our waiting list all the time? Are we making the right decisions? Are we keeping them informed of what's happening and so on? So they don't have a process that works because all they care about is they get an RTT report every month. And I think that's a very, very serious and very deep-seated problem. Now, here's some evidence that it can be better. And what I'm showing here is not recommendations about particular tools that ought to be used or a belief that there are any magic bullets, because I don't think there are. But all three of these examples, the big improvements that people have got. So in the first case, there's a particular tool. Whole ICB has applied this tool to a lot of their waiting list, and they realized that they could do a much better job for all their patients, minimizing the amount of emergency stuff happening to the patients while they were waiting on the list, simply by organizing that process behind the waiting list more effectively. The second example, a very recent last year, that's recent enough, there was a trust which decided to contact everybody on its waiting list. You might say, well, why aren't they doing that routinely? But they did it, and pretty much as soon as they got the feedback, 10% of the waiting list disappeared because they'd updated the status of patients. And you think, how is that not routine? But this was a big improvement story. And the final one, there's a little bit more detail because Palantir have talked about why, and I really don't want to get into the issue whether Palantir is a good thing. But when you understand what some of their case studies actually achieved, you realize that there's a big opportunity, not just for Palantir, but for everybody else to do a better job. So this story appeared in the Financial Times last year, but I also have been to talk to Palantir to double check some of the facts. So at Chelsea and Westminster, what Palantir discovered was that in order to make any good decision about any patient on a waiting list, someone in the hospital had to maybe log into somewhere between 6 and 8 different IT systems in order to pull together all the relevant stuff about making a decision about a waiting list. So patient demographics, patient history, theatre schedule, whether doctors were free on a particular day, what the appointment booking system looked like, and more than that. And one of the reasons why they were doing a bad job of managing the list was because that's a very manual, very person-intensive process. And all Palantir did was to automatically join all those different data systems together so that a single individual could instantly get all the relevant facts necessary to make the next decision about each patient. And that was a huge improvement, reduced the waiting list, but also probably meant they did a much better job. Palantir is not doing anything magic here. It's simply doing stuff which should have been designed into the systems in the first place. But apparently nobody had noticed was not. So that's basically the point I want to make. We can talk about improvement techniques and everything else, but the first thing in understanding improvement is, where do we need to pay attention to what's happening? And if you recognize that waiting lists are basically a catastrophe where nobody has bothered to manage them properly, well, I can't say nobody, but the majority of hospitals, I think it's fairly clear to say, if we paid attention to how we're doing the waiting list, how we make decisions, then we would find enormous ways to improve, and we would get a large amount of improvement. So pay attention to the process. There aren't any magic bullets, but you will, if you pay attention, be able to find big improvements. So that's what I want to say.
Thank you very much, Steve. And I think the thing that you're setting out there is, oh, I'm back again. The thing you're setting out there very much is the bedrock of improvement. It's understanding the problem. And if we are basing our decisions on the wrong information, then we are likely to try and put the wrong improvements in place. I think there was an interesting question that I did notice fly through the chat there, and trying to sort of contrast the information that Chris gave us about people waiting well and the potential health inequalities that develop in that. When we try to validate waiting lists, how do we make sure that validation doesn't exacerbate health inequalities because some people are easier to contact than others?
Oh, that's a good question. I think that I can't absolutely guarantee this is true for waiting lists in general, but I'm fairly sure it's true in primary care, where I have a lot more evidence about who the patients are. I think it's a myth that there's a strong inability to contact people because of, say, deprivation or other things. I think the vast majority of people will have actually the vast majority of people probably have a smartphone. So if you have good information about the patients, you will have a good way to contact the patients. And the trick is keeping it up to date, not assuming that what you had 5 years ago is still valid. So if your process is good, you will be able to contact patients and find ways to do so.
Excellent. So yet again, that is understanding and developing a process to maintain contact with people. Thank you, Steve. That's really good. I'd like to bring Goody in now, if I can. Goody, really interested in your perspective on a sort of a practical Q Exchange project, but also your much wider experience, which I think would be really, really informative to the sort of conversation we started here.
Well, thank you. And hello, everyone. My name is Goody Singh, and I have to say that this was not meant to happen to me. So if we could have the next slide, please. As a brown girl growing up in the working class town in the northeast of England, I was told that people like me don't amount to very much. And the idea that I might be in charge of anything, of leading my own team, planning my own projects and handling money, that was for other people not like me. But here we are. WHAM, the Wellbeing and Health Action Movement, our little organization that empowers clinicians to address health inequalities, not only grew in 2023, but also won one of the Q Exchange Awards for our project, Powering Up, for which we're very grateful and thank you. Now, I'm a pediatrician who works on health inequalities, and I focus on what health professionals should do about them. Next slide, please. But what can a humble pediatrician have to teach anyone, let alone something as technical as waiting lists to a bunch of very smart improvement specialists like you guys? Now, I do not pretend to have the answers, but I do have lots of questions. And so I'm hoping you will be able to help me. Next slide, please. But first, I'm going to tell you a little story because I am a pediatrician after all. Next slide, please. Once upon a time, in a faraway kingdom, 4.2 million children lived in poverty. The country's leaders boasted that it was the 5th richest country in the world, while almost 2 million children went to bed hungry every single night. Ordinary people, next slide please, were told that they needed to tighten their belts and to save the economy. Jobs were cut, Wages were stagnant, and all the nice things they'd taken for granted, like local libraries, children's centres, and affordable housing, were taken away. Things got so bad that even hospitals weren't safe. Beds, nurses, admin, everything dwindled to such low levels that each day felt like a battle. The National Health Service, the jewel in the kingdom's crown, ended up having to pick up the pieces of a broken society. Bruised and battered, it didn't take long for this jewel to lose its shine. Next slide, please. Now, when I was a little girl, I had a dream. And I had a dream that I would become a doctor and that I would save the world. Because medicine, I was told, is great. Doctors are heroes and we can make miracles happen. But fast forward 25 years later, and as a character in this story, nothing I did as a doctor felt even close to being miraculous. Next slide, please. Instead, fractured, frazzled, and frustrated, I spent my night shifts feeling like a failure. What can I offer Frankie, the 3-year-old who's come in with a chest infection, but who I find has the bowed legs and skin rashes of rickets and pellagra, Victorian diseases that I'm not supposed to be seeing in the 21st century Britain? And how can I explain to Farid, the 16-year-old Syrian refugee who has lost his entire family on the way to the UK, that even though he's feeling suicidal and anguished, he has to wait with the grown-ups in A&E because he doesn't look like a kid? I started to see that our health system punishes those who fail to turn up or who seem to disobey our orders. The attitude of one strike and you're out is still going strong. But how does that help those who find it hard to take their meds when they can't read? How does it help to tell teenagers to exercise more when they live near polluted highways? How does it help to send patients home with drugs that don't work, only to have to see them again the following week in a medical version of Groundhog Day? Now, some of you in the audience may well have switched off to scroll your email or WhatsApp because public health and social factors, well, they're not really medicine or improvement science, are they? And that's what my bosses said to me too. Next slide, please. And I'll be honest, I became a bit depressed when I realized that our profession didn't really care about whether patients had enough of the right kind of food to eat or money to pay their heating bills. And over again, I'd be told, that's someone else's job, sweetheart. But whose? The thing about this story is that it's true. This is the state of health in the UK today, and nothing in my training had prepared me for it, for feeling helpless. I spent years feeling disappointed, disheartened, and burnt out from working in a health system that seemed to care more about sickness than it does about health. And to me, pediatrics and the very health profession itself felt useless, if not downright irrelevant to real people's needs. Finally, I decided enough was enough, and either things were going to change or I was going to quit medicine. Next slide, please. Next slide. So while there is no happily ever after to this story, the very fact that I'm here talking to you today means that I may not have left medicine. Next slide, please. And instead, I ended up in what feels like a never-ending interdisciplinary PhD in applied philosophy and critical social sciences, which to some people is about as close to just career suicide as it gets. Now, what it has led me to see is that what is going on here is a kind of blindness. Next slide, please. And what I paradoxically call the clinical gaze. Now, I haven't written my thesis yet, but in short, on the one hand, medicine is blind to the antecedent drivers that bring patients to our doorstep, the social context of this disease. And on the other, medicine is blind to the particularities of the human at the center of it all, and to the richness of data beyond the quantitative. Now, the worst part is that as a profession, we let it happen, and thus we are blind to our own complicity in the whole mess. Now, the reason that I haven't burdened you with a single graph or statistic today is because we've seen and heard it all before. I don't need to tell you, because even if you were unaware of health inequalities pre-2020, COVID blew the cover off that scandal, and no one can pretend that health inequalities don't exist anymore. For years now, next slide please, we've had edicts from all the important places telling us that health inequalities exist, that they are wrong, and that we should be making every contact count. We've also had declarations about the importance of the voice of the child and ideas like co-production and patient-centered care bandied around for decades. And yet nothing has changed. Health inequalities are wide, and despite increasing attention, things are not getting better. Now, be honest with yourself. How much of your practice actually changed in light of any report that Michael Marmot has produced? And how much of your practice has changed to genuinely put patients in charge of their care? How much of your practice has changed to consider your own role in exacerbating health inequalities? My PhD is ultimately about what clinicians ought to be doing in the face of social realities in people's lives. How do we solve 21st century health problems with 20th century tools? Next slide, please. One thing is clear. We will never address the issue of waiting lists or truly improve access to care until we address the blindness that pervades the healthcare system. And to me, this is not an academic question, and the answer cannot wait. I feel the urgency in my bones every time I deal with another deprived family in A&E. Every time I have to empty my wallet in clinic to make sure a child does not go home hungrier at night. The answer cannot wait because patients cannot wait. Now, I started to think about ways that we could try to address health inequalities from within clinical practice, and I started to use whatever tools I had to hand, including QI, and I started doing research into what this might look like. People started to pay attention, so I kept doing it. Next slide. And the more I spoke about it, the more people seemed interested in what I was getting up to. And that's when I realized that other people also wanted to do things differently. But it's one thing to have a feeling that things are not right, and quite another to do something about it. Next slide. That's where WHAM comes in. WHAM, the Wellbeing and Health Action Movement, is an empowering through education organization, and it was formed in 2021 by a bunch of pediatric trainees like me in response to health inequality in the wake of COVID-19. Now, WHAM is a true Q baby in that, next slide please, it sees itself as a social incubator and digital platform for the peer-to-peer sharing of the knowledge, tools and community to inform, empower and unite clinicians who wish to address social determinants and health inequality in clinical practice. WHAM exists because if the health profession wants to move beyond words towards genuine action on health inequality, then we have to take responsibility for developing the know-how, skills and networks we need for ourselves. Next slide. Next slide, please. We need a new way to practice medicine, one that creates health, not just fixes disease, and one that sees the whole patient, not just individual organs, one that understands that health fundamentally needs social justice. Now, if WHAM is about taking tools such as QI to translate individual action into transformation of the medical profession, then Powering Up is our attempt to learn how to meaningfully put service users at the front and center of that journey. Next slide, please. And the idea is that they can help to address health inequalities both in their own lives and in health systems, and all through a process of creative co-production. So in Powering Up, young people with long-term conditions in deprived areas are going to work with clinicians like me, but as equals, and we're aiming to help make health better. Now, it's about genuine collaboration, it's about partnership, it's about using film, music, and dance to do it. It's about empowering young people while upskilling clinicians so that we can do better. It's about shifting power, and it's about leveling hierarchies. Next slide. It's flipping exciting, but I'm bricking it because now I'm on the hook. It's not about success, whatever that looks like. No, much more important than any of that is the how, the values that permeate the project from inception to completion. Because it's not enough to espouse ideals of equality on paper, only to fail where it really matters, in practice, in the everyday reality of our lives. And that's why, next slide, I am delighted that Powering Up is not just for young people, but genuinely by young people. We have already employed 2 young people, or young stars, who have been part of our process since day one. They are helping to shape every aspect of this project, from vision to implementation. Even the logo and the mascots you see there have been designed by them. And we've only been going for 3 weeks. But because we've only just started, I don't have a glossy report to tell you all about our impact yet. What I can tell you, next slide, is that we're having loads of fun and that I have never been more stretched or learned as much in my life. But this is no fairy tale. What does it really mean to share power with service users? And how can we do that in a way that enables them without overburdening them? You know, what we're attempting here is big, but the truth is we are tiny. And though it's me who's talking to you today, I want to just take this moment to pay homage to the incredible Aisha Bouraoui and Mary Salama, who are on either side of me in that picture, and who are also members of Q and who are co-leading this project. I am blessed to have them by my side, as well as the rest of my amazing team, because We all have the humility to know that we may not pull this off. But we also have the courage to keep going until things hopefully finally change. Now, I am not sure I will ever believe that I'm meant to be doing this. But for now, I have no choice, because the young people who work alongside me and the young people we are hoping to engage are looking to us to find the way, right? We just need to find the power ourselves to get there. Now, this is where you come in. Next slide. Because we would love for you to help us. We would love for you to stay tuned as Powering Up unfolds in the coming months. And there are 3 really easy ways that you can do that: by joining WAM, following us on Instagram, and writing to us if you think you can help. Because the fact is that if you believe in what we're doing and you want to be part of a movement for fairer, better healthcare, then welcome to the family. Please spread the word. I would like to thank you for the opportunity to do this project, for the opportunity to share our story today. And I'm really looking forward to having a discussion with you on this and more shortly. Thanks.
Oh, thank you, Goody. Yeah, I'm glad you didn't stop being a doctor. That's quite inspiring.
Well, I guess it's you're lucky that I'm still here to talk about it.
Oh, no, we appreciate it. I was really struck with the thing that you said about people, the one strike thing, that if people don't comply with a service, then they're penalised. Do you think there is a sense that that's intentional in the way that people have designed services, or is it just a horrible accident?
I mean, look, there is, if you read my PhD, which is yet to be written, but in there is a lot about, and, you know, we talk about this a lot in improvement, right? We talk about cultures. And there is a culture within medicine. I'm not going to speak for the other health professions because they're actually thankfully different to medicine. But there is a culture within this which actually has hierarchy built into it. And so there is, I'm sad to say, but there is probably in some sectors, not all of them, a persisting belief that doctors are somewhere different to where patients are. And so it's almost like we build barriers into the system automatically. It actually comes back to what Stephen was saying, right? About the problems are in the way we build the system right from the beginning. And so we're dealing with all those problems kind of later down the line. And it kind of leads again back to what Chris was saying, because patients are having to jump through all sorts of obstacles to even get on a waiting list, let alone then have to wait for treatment. So I don't think it's something that we do intentionally, but I think the way that the system is constructed means that it's almost inevitable in current situation.
So I think the culture particularly resonates with me. Can we bring Steve and Chris back?
Yeah.
Excellent. Welcome back. Chris, you look like you've got a question there.
No, I was just reflecting on some of the stuff that Goody had to say. So, you know, you often hear like for instance, I did not attend, as if it's just something that just happens, you know, and it's about until you understand the reasons why a patient may not have been able to attend an appointment. A, could they afford to travel to it? Or B, for instance, quite often it'd be somebody on a 0 hours contract who isn't able to get the time off on that particular day because they just can't afford to. And like all too often, it's you know, those people who aren't able to attend and who get that strike against their name, as Goody was referring to it. It's often there's a good reason as to why they weren't able to attend. So the system really needs to understand that the pressures that individual patients are under and why patients behave the way that they do.
I'll just add something to that, because did not attend is a big problem. I mean, everybody complains about it, and there's even politicians saying we should fine patients if they don't turn up. But I think AccuRx did a study sometime in the last couple of months where they actually surveyed patients who hadn't attended appointments and tried to find out why. And I think the majority of the reasons were because the process of contacting the patient was broken, not because the patient had, you know, some patients, yes, they can't travel to the appointments or they've got a 0 hour contract. But if the majority of the reasons why the patients didn't turn up were in the hands of the hospital, that's appalling. How do we let that happen? I mean, the same thing is actually true with GPs. We know that for GP appointments, there's a very, very strong relationship between how rapidly the GP gives you an appointment slot and how many people are likely not to turn up. If you get a same-day appointment, it's 1%. If you get an appointment next week, it's 10%. The GPs could control that.
Yeah, and it's interesting that you're both saying something that I hear so much in my own practice, which is that we talk about this, the hard to reach populations. But the truth is that the ones who are hard to reach are specialists like me, right? You know, because we're just protected by so many levels of bureaucracy or referral pathways. And it just seems that, again, it's that kind of thing with the culture. We're wanting to blame the patient when we should be turning the lens back onto ourselves and actually asking, like, where is our DNA in this? What are we doing that's meaning that actually we are the ones that are hard to reach? And how do we start breaking some of those barriers down? I mean, like, that's partly what Powering Up is looking at. We're going to be asking that question of young people. Like, what is it that means that you don't want to come and talk to me about your health problems, and that you don't feel like the NHS or the health systems in general can help you? Because I think the very fact that that is even a question that I'm asking is saying that we're failing, right? We're not serving our patients.
It really sounds like the message I'm getting from all of you is just understand the people that make up the waiting list is the real challenge for us. And I think when we have that sort of pure numbers focus on whether lists are going up and down, when we don't create the space and the room to understand the people we're trying to support.
Yeah, and another big factor is the accessibility of information. So since 2016, the NHS has had an accessible information standard. But when we did some work on that a couple of years ago, we found that the implementation of that across the system is, there's a real marked difference. So some of the people that he was talking about, so somebody who from English is their first language, or a child whatsoever, or perhaps somebody with a sensory impairment, that their needs are not always met. So if patients aren't able to get the information they need, how can we possibly expect them to be what the service might sort of rate as compliant, because they're just not receiving the information they need in a format that they need it to allow them to understand how to navigate the system.
Yeah, and if the hospital hasn't been in contact with any of the patients or stored that sort of information, maybe we need a translator, maybe we need something that helps someone who's got restricted sight, if they're going to be able to understand where they are. But if the hospital doesn't even contact them, it doesn't know any of that, and it doesn't pick the right contact mechanism, and there's just nothing in the process which overcomes those difficulties.
I've got a really interesting point from Aisha that was put in the chat. We need to spend more time defining the value of people using the services before we leap to solutions, and that sort of plays to my sort of improvement mindset. Do we really understand the value that our services are creating for people beyond the sort of simple, relatively simple medical interventions?
I think, just a relevant piece of evidence is that if you keep up to date with the patient's current status, you sometimes do things which helps out the patient's current health, even before you've got them the thing they're waiting for in the hospital. So if you don't contact them, you can't know any of that. If you don't keep up to date, you don't know it. But as I say, I think the strategy unit produced a big report several years ago where they tried to count how many emergency appointments in hospitals were caused because people had waited for a long time on the waiting list. And they had a pretty big number of the excess emergency, A&E attendance calls because a patient had not been maintained properly while they were on the waiting list. And say, we need to understand it's not just getting them to a clinical procedure; it's keeping their health while they wait for the procedure.
Yeah, exactly. And I think this comes back to what we were talking about before, which is like, what are health systems for? Right? What are we all for in this whole big behemoth that's millions is being spent on? That's how you'll define value, right? And we can't define value on our own. We need to, if the whole point is to serve the population, they need to be part of these discussions. And what is it they want? I don't think we've done that enough. We are starting to, of course we are. And Q is one of those places where the people who think like that can come together and they can start kind of breaking that new ground. But the truth is, like, the most of the NHS does not ask this question because we can't, because we are under such huge pressure to literally deliver services according to incentives that have already been set for us. So Stephen mentioned before about how these processes are skewed because of incentives that actually have nothing to do with what matters to patients or health professionals, right? Nothing to do with what is actually in their best interests. And so it means that these health systems are not about patient welfare in some sense, right? It's literally about KPIs, or how quickly certain things are done, or how much tariffs, the tariffs that are kind of charged in the back of the system. All the stuff that we don't actually see if you're a health professional or a patient. None of that stuff is visible to us, and so we actually don't understand why there are waiting lists in that same way. And so there's a whole opacity of the system. It's all of those incentives and things that are at the back of it which actually control what happens at the front. And, I think there's something about transparency and lifting the veil on this and having an honest discussion about what it is that's driving a health system. And it ultimately comes down to Aisha's question there. What is the value here? What is it that we are seeking to deliver in the world? And until we have a good answer to that, I think we're just going to be going round and round in circles.
Yeah, I totally agree. I mean, the goal is not minimizing the number of RTT breaches. The goal is improving the health of the patients you've got.
And in talking to our community, I get no sense that people are not incentivized to work, and it's whether the actual sort of data collection is the thing that motivates people during the day. But what can we do as improvement specialists to lobby for change in that sort of incentivization?
Well, the thing for me about it is it's not just data collection, and then it's where that data goes once it's been collected. Because one of the things which is a really inefficient use of time in the system is that every time a patient sees a clinician, they're having to re-explain their condition to somebody, and they've maybe already done it 2 or 3 times. So it's frustrating for clinicians. It's very frustrating for patients. So if we can improve data flows across the system, you could probably create serious efficiencies.
Totally agree.
I think Chris's opening was just really interesting to me, because it kind of put numbers to what I kind of intuitively know, which is that it's just really difficult for patients to even get to see me in the first place. I just hear about patients talking about having to wait literally 4 or 5 years to see a specialist for autism diagnosis, or whatever it is that I happen to be, delivering that day. But it's more than just kind of whether they get to see the specialist and whether they have the appointment. Maybe we should be asking, maybe they didn't need that appointment in the first place. Maybe there's something better for them out there in the world. And that's, again, this thing of what is it? What are we for? If we're about health and not necessarily just about doing our job, how might we configure things differently? Or how might we guide people to what's actually going to help them? Because it might be that actually seeing me is the least helpful thing in the whole scheme of things. Or actually, how much can a specialist help in some of these issues, especially the social issues? As a doctor, there's actually very little that I can do. And so again, I feel like if we took a step back and thought about the whole system and not just what doctors are doing, or one element of it, the acute part of the system, actually we would think very differently about how patients are even brought into the system in the first place, let alone where they end up.
I think that's really...
I would just add one thing to that I think there's a very broad problem in thinking about improvement in healthcare. It's that people look at little narrow silos of activity and try to solve the problem in that. Very few of them think, how does the whole system fit together? And where are the bottlenecks? Where are the big barriers that affect lots of other things across the system? So understanding the system is a really important thing that not enough people do.
Well, that also brings in that if we're talking about integrated care and how things flow across the system, which is kind of the elephant in the room that doesn't get talked about, is social care, and how issues around discharge cause a real problem, because on any given day there are thousands of people in hospital who are fit to be discharged, but there is nowhere to send them to. And if you could solve that problem, you could actually go quite a way to relieving the bottle care that there is around elective care. The bottleneck, sorry.
Okay. What Laura's raised a point in the chat here about the needs for virtual consults and being able to provide people the medium that is best for them. Do you think we do offer the widest range of different ways that you can access services possible, or are we more sort of focused on what the best interests of the system are?
Oh, I think Chris is the one to answer this question.
Yeah, the thing that needs to be done on this thing is that needs to be understood what the patient's preferences are. For some people, right, a remote consultation works really, really well for them. You know, say somebody who has mobility issues or has caring responsibilities, they might prefer a remote consultation. But for some people, they want that face-to-face consultation, particularly if they're talking about an issue potentially to do with, say, mental health or sexual health, whatsoever. They want that face-to-face. The key to that is actually making sure that systems and practices are recording the preferences of individual patients. You know, because like for myself, I'm quite happy to do a digital consultation. I'm very comfortable on a laptop. I know, but not everybody's like that. And also not to make assumptions, because there's assumptions that are made, for instance, that older people really don't want digital or remote consultations, and younger people are happy with it. And that's not always the case. For instance, younger people might not actually have, if they live in a shared household, might not have a private space to do their consultation remotely, and might actually be required to go into the practice. So it's having that understanding of the patient's preference and what works best for them, and making sure that you're offering individual the mode of consultation that works best for them.
Yeah, I think that's a big point. I think different parts of the health system have been very resistant to looking at alternative, more efficient ways to actually do the thing that needs to be done at that step in a patient's journey. So hospitals, very often, a lot of the outpatient stages of a waiting list could easily be done remotely or with a virtual consultation. And that's probably simpler and easier than trying to bring the patient to a physical location. And we're absolutely certain this is true with GPs, although GPs are very resistant to this idea. The majority of patients, given a proper choice between a face-to-face appointment with a GP or an online response or a video call or a telephone call, only about 20% of the patients choose a face-to-face appointment. And yet GPs themselves, GPs are not very uniform, so I shouldn't generalize, but a lot of GPs are trying to maximize the number of face-to-face appointments. And actually, patients have to travel for that. That's a problem. That costs them money. That's a problem. Honestly, a phone call would resolve it and do it faster than a face-to-face appointment. That's a waste of GP resources. So it's really, we do have some evidence, but it's not been widely spread across the system about what patients really want. I think that's true for hospital appointments as well, but there's even less attention there.
Totally. Oh, sorry.
There is one risk with that, and that is about people who don't have that digital connectivity. One of the recommendations that I think it was the Lords Select Committee made was that the potential to look at the ability to access health services online as a sort of a universal right, so that nobody had to face data charges or anything for contacting their local health services, to making sure that you don't end up actually putting up another barrier to some people if we move to a model of much higher numbers of digital consultations.
Well, I think that's often used as a reason not to try digital things. But the issue is, if you understand the patient, you probably understand which groups are the ones who need to physically turn up. I mean, a GP. So GPs, for example, who've got really good remote access or online access, they don't cut off access by call them up and ask for a proper appointment, and they don't cut off access for people to walk in. In fact, if you get 2/3 of your patients online doing the queries, the phone lines turn out not to be busy, and everybody else.
I agree with you, Stephen. My point is just that there will be some people who could be adversely affected by any digital as an extra barrier, and it might not be many, but we just make sure that actually it's none.
Absolutely.
And I think what this speaks to, you're both saying exactly the same thing. You're coming from the right place, which is to say that, like, I think every individual patient needs to be met on their own terms in some sense, right? There's something about trying, to the extent that it's possible within a service that's trying to be universal, to be also bespoke at the same time. And I know that as a challenge. I'm not saying that this is going to be something we're going to solve overnight, but it is a bit of a shift in like emphasis and focus. We wanted to provide standardized care where everybody got the same, but actually that doesn't produce equity. And so there's something about, it can't always be the same care for everybody, but it might just be the care that they need, and that will make all the difference. And I often wonder, especially with some of the families that are waiting to see me, might they feel differently about being on a waiting list if there had also been at the same time other interventions, non-medical, that they had had access to while they were waiting? So this whole idea of social prescribing, which we kind of pay lip service to. But if all of that begins at the moment a patient is referred to a specialist, you might end up seeing that patients, don't mind waiting, and actually then it's okay when they finally do see me, and that things have progressed, things are different, that they've actually had treatment in some sense. Or they actually may just decide they don't need to see me in the end, and that actually they're, things have been dealt with. I'm not saying this is the answer, but there's something about it being more than just the medical solution, and us thinking much more broadly about what it is we're offering to patients. That I think, again, it's almost like this needs to happen right at the beginning. I don't want to blame GPs just because I know how much pressure they're under, but there's something about whatever system it is that we have for collating people's problems in this country that might be able to triage this a bit better, or to divert people in that way. And I don't know, I'm hoping that the key community collectively will come up with the answers. I don't know if it's just going to be up to the three of us to figure this out.
It would.
I think general lesson is know your patient.
Yes.
Because if you do, you'll be much better able to make those offers to patients that will work for them, as opposed to giving them some generic thing which may not work.
Right.
We've got a few minutes left. I think my reflection on this conversation is I'm just so heartened by the focus on people rather than the numbers. And I think that really stands us in good stead for how we try and address the problems that people have. I'd just like to have a quick whip round across you. What do you think individually is the great opportunity for improvement in this sort of space? Who would like to go first?
I'll go first. For me, if you wanted the quick one, quickest ones and the lowest hanging fruit is improved patient communication. If you're if you're able to make it a two-way communication channel where patients are able to contact their system, their GP provider, their trust, and have that point of contact and feel informed and understand where they are on their pathway, what the delays are likely to be. It is probably the single thing that could be done most easily to improve patient experience, because we know that there are going to be substantial waits for a reasonable length of time. We know that that's not going away very quickly, but you can definitely improve patient experience if you can nail down your patient communication.
Thank you.
Yep, I think I basically agree with that. I think I would maybe express what people need to do slightly differently. If you think about your waiting list as not a big number, but as people, and as a team, you need to understand those people. That improve the communication. You will understand them better. But the big transformation, I guess, is a management transformation. So instead of senior management in hospitals, or for that matter, the whole NHS, thinking about the numbers on the waiting list, they need to think, I could really improve this by devoting effort to managing those people in the most effective way, because we think about them as people, and we need to get the right decisions, the right care. I would call that a management problem, which can be fixed if you put the right people in charge, design the right process, get the communication with the patients right. That will lead to big improvements. Patients will be healthier. Actually, the lists will fall as well.
I agree with both. Oh yeah, I was going to say I agree with both of what you've just said, and I think ultimately for me personally, this comes down to power and where power is held in the system, and powering up. Obviously, our project is all about trying to think about how we're going to rebalance it in this particular situation, but we are having to rethink who we are and looking at this more a relationship with our patients, not as this kind of consultation or like an intervention. And I think the key will be that we will have a new philosophy behind what we're doing in health, and we will have different values seeded into it right from the beginning, so that we're not in this position in 10 years' time and still talking about the same thing. Because ultimately, we have to go back to the beginning in a way, and just make sure that the patient is always at the center of everything we do. And if they are at the center of what we are doing, you just work back from that, don't you? And you're much less likely to make those mistakes. So I ultimately think it's about us being willing to give up some power but for a very good reason, which is that the patients who deserve it will have more power in their hands as a result.
Thank you so much for that. That brings us to the end of our session on weights. For all the people watching, you get an opportunity to participate now. We will put some questions around the value that we've created for you through this conversation in there. It would be really good if you could feedback. But I'd like to thank Goody, Chris and Steve for the time they've given and the insight that you've given, because I think it's really been an interesting conversation, and I think taken the way that we think about weights in a different direction. I'd like to thank you all.
Thanks, folks.